Welcome, everyone. Welcome again to this year's Mental Health Didactic Series. My name is Kyle Rokas. I'm a social worker and a therapist here at ASAP Clinic, and I'm one of the coordinators for the series. And our 55-minute Zoom didactic, it's free. It's presented by an expert in a topic and focused on providing fundamental clinical education to assist professionals working with individuals with mental health diagnoses. And these are just the basics on a topic, so hopefully you can be inspired to go out and learn more outside of here. Please have your mic on mute and write any questions you got in the chat, or we can answer them as we need or at the end. And please also drop in the chat who you are and where you're joining us from. I see some folks doing that already. After today's presentation, you are going to get an email from Erin Watts. She's our other coordinator, and it's going to have today's slides and a link to a survey. Once you complete it by adding your name and your email, you'll be emailed with your CEU certificate. And just a heads up, our didactic series is also honored by the New Mexico Credentialing Board. So for behavioral health professionals of all types, let's go to the next slide here. So for nursing contact hours, you're going to be asked to complete a survey by scanning a QR code at the end. And I'm also going to drop the link in the chat. And once you complete that, you will get your notification in your email that shows the credit for being here today. And if you're sharing this didactic with somebody, please make sure that everyone is registered for the link. There's a link that goes out to get you registered to come here. That's the only way we know that everybody's come, and that's how you get credit and you get those emails.
Yeah, so especially if you're in a big room, so please, if you are looking for CEUs or CNEs for nurses, make sure that you each have your individual registration. So you're appearing as an individual rather than a group. So today is going to be a very interesting topic. I'll go back to the disclosure. Both Jamie and I are presenting today. I promise it's my last one for this semester. But it's going to be a very specific topic to substance use disorders. But I know some of you are more of a generalist, not just substance use disorders, or not just specifically. So kind of lend us an ear today, because we talk about specific items related to substance use treatment. So you might actually come across maybe indirectly, and it's very relevant to all individuals who at any point provide any type of or document any type of substance use service, and is very relevant. So we'll start with Jamie, and then we'll end up with an approach to matching care. So I have nothing to disclose. There's no monetary value or compensation, into what we're presenting or the content of it. And then I present to you, Jamie. And
hi, everybody. My name is Jamie Stockey, and I'm the unit director here at the ASAP program. I also help with the nursing staff at the CARE campus, which is a county-run facility where we do inpatient detox from substances. So I'll be, if you want to go to the next slide. So I'll be presenting on what's called 42 CFR Part 2. And what that entails, you can go to the next slide. So what that entails is talking about the confidentiality of patients who have substance use disorder diagnoses and making sure that their information is protected. This is a layer on top of HIPAA compliance. So everybody in the medical field has to comply with HIPAA regulations, but this is even a higher layer that's called 42 CFR Part 2 that protects patients with substance use disorders. But it's very specific to programs who their primary treatment is of substance use disorders. So if, for instance, a primary care provider is providing substance use care, or they're providing a Suboxone prescription or something like that, they wouldn't fall in this category and they wouldn't have to comply with these regulations. This is for federally funded programs who their primary treatment is for substance use disorders, much like the ASAP program is. So we do fall under this rule. It was revised in 2020, which had been years, like 20 plus years since it had been revised. So there are some new rules and different changes that happened with the 42 CFR. I will discuss all those changes today, and hopefully, and there's exceptions to the rule as well, which I will discuss as well. You can go to the next slide. So first, let's talk about what didn't change. So what didn't change is the overall framework of 42 CFR. So the definition, which I just talked about, did not change. So still the same places apply. And the general rule for disclosure is that whenever possible, we need a written consent for our patients in order to share any of their information. That's the general, even for HIPAA, right? Whenever possible, we should have a written consent for a patient before we disclose any information to any other entity or provider or whoever we're speaking to about the patient care. So that is the general rule that did not change. And then the enforcement of the rule also didn't change, and it's actually become much stricter. I've heard of facilities actually getting fines for not following these 42 CFR rules. You can go to the next slide. So there's three major topics that did change. So we'll talk about first disclosures with patients' consents. We'll talk about the exceptions that I talked about, and then just the technical and practical guidance of this rule. So disclosures with consent. So before the 2020 changes, if you have a release of information and you're a Part 2 program, you had to write a specific treating provider in the field of who you're releasing to or who you're getting information from. So for instance, I'd had to put their specific PCP, Dr. Gonzalez, into the line. We could not put a generalization. If Dr. Gonzalez worked at UNM hospitals, we couldn't put just UNM hospitals. We had to be very specific. So as most of you know, UNM, Presbyterian, places like that, they get their patients get care at multiple facilities within that big organization. So you had to send a consent for every single one of those individual providers before this change happened. Now you can put a general entity into that disclosure, and it works for all of UNM, all of Presbyterian, or all of First Choice, whatever it is. You can put the entity in now, and it'll cover you for the 42 CFR and the records. You can go to the next slide. So verbal disclosure, that also changed. So before you were if you gave information verbally about a patient, it used to have to be protected over Part 2 rules. It no longer does, but let me clarify. So that means, for instance, a patient at ASAP has a primary care provider outside of UNM. And we need to talk to that primary care provider because they're prescribing a medication that we would like to discuss with them, or that primary care provider would like to discuss it with us. We need a written consent to start with to be able to talk to that primary care provider. That is still in play. We need that consent. However, once I'm on the phone with the primary care provider and we're discussing the patient's treatment, whatever that provider, the primary care provider, then puts in their note from their medical record, in their own medical record, whatever they discuss, we discuss with them, we disclose with them, and they write into their own medical record, that is no longer protected by Part 240 or 42 CFR. So whatever goes into their record is then open for other people. I mean, obviously it still falls under the HIPAA rules, but I think the important part of this is that we are always communicating with our patients when we're disclosing information. They shouldn't be surprised by it. They shouldn't look at their primary care notes and say, wow, I wasn't aware that my primary care had a conversation with ASAP or with my Part 2 program. I think it's important, while that's not protected by the Part 2, we should do our due diligence to always tell our patients when we're having conversations and discussing those types of that type of information with outside entities or providers. I just want to clarify, though, that if you're going to send anything written, which we'll talk about again, but anything written electronically, an email, faxing, whatever that is, it always has to have a consent before you send that. That has not changed. You can go to the next slide. So we'll just do a small case study real quick. So Mary receives substance use treatment services at ASAP, for instance. She signs a consent to authorize the ASAP program to share information with her PCP, which is at a different local clinic. The PCP has a brief phone consult with the Part 2 program. The Part 2 program, so ASAP, sends a secure email with the PCP to the PCP with Mary's recent treatment records. And then Mary meets with her PCP and discusses her SUD treatment. So you can go to the next slide. Which of these three would be covered or protected under Part 2? You can either write it in the chat or you can come on mute, either one. Would it be all, one, or two of them?
Are you able to see the chat? We have all.
Yeah, I'm looking at the chat here. Yeah. Okay. So I'm seeing all a lot. I'm seeing 4. I'm seeing number 2. All. Okay. Okay. So notes from the phone conversation are actually not protected. So those notes that the PCP takes are actually not protected anymore. You can go to the next slide because it'll talk. Okay. So they're no longer protected if that phone conversation happens. So if it's anything verbal, this is new. This changed in 2020. Okay. So the verbal conversation is not protected. The email, because it's electronic and anything on paper, is protected and always has been protected. And then, like always, Mary, that anything she shares with her PCP on her own time, that is not protected under Part 2 because it's not a Part 2 program, and that's always been the case. So if Mary chooses to share that information with her PCP and she puts that information, that PCP puts it in their EMR, that is not protected by 42. It is protected by HIPAA, but it is not protected by 42 CFR. Go ahead and go to the next slide. So again, I kind of already talked about this, but I'll keep repeating it, that Mary probably doesn't know which information we're giving verbally to her PCP, and she probably is not expected to see her substance use history or treatment information in her primary care's EMR. So again, we just really need to be careful what we're sharing. Yes, it might be legal that we're sharing it, but we need to make sure we're communicating with the patient exactly what we are sharing so there's no surprises. And then any information now that this information may now be shared and redisclosed because of HIPAA standards. HIPAA standards allows redisclosure once it's outside of the Part 2, and that's just a normal HIPAA rule. So again, patients might be surprised by that when they see it in other people in their chart elsewhere. So please be careful when you're sharing information. You can go to the next slide. So redisclosure. So really, this is just if you're a Part 2 program and you have a release of information, that release of information must have this prohibition on redisclosure notice. There's a long version and a short version. Either one is fine, but it has to be on there. It's part of the law. So you can put the long version. There's new language for the long version if you feel more comfortable that way, or you can put the short version that just says 42 CFR Part 2 prohibits unauthorized disclosure of these records. Very simple, but one of those two statements must be on all of your releases of information. And also that what changed is it clarifies that the redisclosure only applies to the Part 2 records. So there was confusion that if there was Part 2 SUD records in a record, then the whole record had to be protected by Part 2. And that's really important for UNM providers because at ACEP, we're part of a larger organization of UNM hospitals. And so because our notes are in the patient's chart doesn't make all of their chart a Part 2 protection. Only our notes need to be protected by Part 2. So I think they made clarifications of that so that people aren't confused that the entire record does not go under Part 2. You can move to the next slide. Is it not moving to the next slide? Oh, there it goes. Okay. All right, so state central registries. So what a state registry is it's just central online registry where you can go and look and see if patients specifically are on some kind of substance use disorder medication, such as methadone, Suboxone, things like that. So if they're part of an opioid treatment program, and they're getting methadone or Suboxone, there's a central place that we can go look and see if a patient is on one of those medications, see what last dose they took, when was it, how much was it, how many milligrams was it. So this is a central registry. So the reason what the 42 CFR decided to do was allow other providers to get on this registry so that it would prevent things such as multiple program enrollments, prevent duplicate prescriptions. And, the big one was this third one was informed prescriber decision-making regarding prescribing opiate medications. However, it's up to each state whether they want to comply with this state registry. So in New Mexico specifically, we are not required to allow other providers on our central registry. We do have one, and all other opioid treatment programs have access to this registry, but outside prescribers right now do not have access to this registry. And that is a state decision that they have made that decision. And in my opinion, it does help protect our patients a little bit more because there is still stigma, as we know. Providers do treat our patients differently when they know that there is a substance use disorder. They tend to prescribe differently when they know there's a substance use disorder. And so the state has made the decision to not allow other providers at this time to have access to this registry, but we do with it OTP, so we can definitely make sure they're not enrolling in other programs and other methadone programs and such, and dual dosing with methadone. So there is some, but not the full extent of all providers being able to see this. You can go to the next slide. So PDMPs, the prescription drug monitoring programs, everybody hopefully has heard of this by now, but it's again very similar to the registries, where it's an online system where we can go in and look up a patient, and if any patient has picked up a scheduled medication, a narcotic, or any kind of scheduled medication, at any local pharmacy, it'll tell us what medication, who prescribed it, when it was prescribed, if it has refills, what provider prescribed it, and so on and so on. And about 95% of pharmacies have to be part of this program. One of the only exceptions is the federal pharmacy. So VA pharmacy is currently not on the PMP, but most other pharmacies are required by law to be part of the PDMP. And they have a system that automatically uploads it to the PMP every day. So when a patient picks up a prescription, it's not like the pharmacy's having to manually go into the PMP and enter everything. So what changed with Part 242 CFR is now we are allowed to put things like methadone and Suboxone that are prescribed in an OTP, we're allowed to put them in the PMP. However, it has to have a written consent by the patient in order to do so. So right now, this is again up to each state if they are making this mandatory or not. Currently, the state of New Mexico, it is not mandatory. It's highly encouraged, but it's not required. And there's several reasons for that, I believe. I think one is you have to have a written consent, and we know the likelihood of a patient saying, yes, of course, go ahead and put my methadone and Suboxone dosage on the PMP for everyone else to see is very unlikely. I highly doubt most patients are going to agree to that, and we can't upload it unless the patient signs each consent. Also, there is no automated system yet, just much like the pharmacies have that automated system, automatically does it up to the PMP. We don't have that. So we'd have to manually enter every day. And, when patients are on methadone, it can dose multiple days a week, multiple times a week, sometimes daily. And so every day we would have to upload manually to the PMP, only the patients that consented to their doses. So this is not yet a requirement, but I do see in the future that this could be a requirement, hopefully once they have a automated system that can do that. And then the PMP system is required to make sure that those records are being protected from law enforcement. So that's on them to do that. So exceptions. So exceptions to these rules, there's 9 exceptions to having a written consent in a Part 2 program. I'm not going to talk about all 9. I'm going to talk about the 4 that are in light blue. The other ones are a little more self-explanatory, and all of my resources are at the end. So you will get this slide and you can research these yourself if you would like more information on them. So first we'll talk about medical emergencies. You can go to the next slide. So medical emergencies is Part 2 programs are allowed to share if there's a bona fide medical emergency, such as the pandemic, which we'll talk about. So if there's a state of emergency in the nation, state of emergency in your state, that would fall under this. Also, if the program is not able to be open for natural disaster, for instance, so there was a fire or something happened and that program is not able to be open, that's another reason why you wouldn't need a written consent and could do a verbal if needed. So the pandemic was a perfect example of us having to implement this. So if you go to the next slide. So let's talk about some of the needs that happened during COVID. A lot of these programs and a lot of providers were closing their doors and or not open all of the time. They were limiting their availability. Patients weren't able to come to in person because they were sick or they needed to be in quarantine or whatever that was. They didn't have transportation. A lot of services that our patients need were shut down or limited because of other people not working. We needed an increase of telehealth services and telephonic services. And so written consent wasn't available all the time. We weren't able to get written consent all the time. And so what changed is the provider was able to make the decision whether it was a medical emergency or not. Since we are under a national state of emergency, we didn't have to do this. But in an instance that where it's clinic specific or program specific, your medical provider can make the determination whether it's considered a medical emergency and you can release the information without the consent. We could only exchange information to medical personnel for treatment purposes only. We were not allowed to do it for any other reason. You couldn't do it third-party payers, anything like that. You had to only for medical purposes. For treatment of that patient could you release information. You were allowed to redisclose, which is not normal. So if you're in a state of emergency, you're allowed to redisclose for treatment purposes only without a written consent. But it's important that you document everything. So everything needs to be documented, that you release this information. There was no consent, but this is why. So that's very clear that there was a treatment purpose to why you release that information. And then whenever possible, you need to get at least a verbal from the patient, whether it's over the phone or by telehealth. You need to at least get a verbal consent from the patient that it's okay to do so. Go to the next slide. So I'm not an expert in research, so I'm literally just going to read these because I'm just not. But the Part 2 programs and lawful holders may now share data with entities subject to FDA regulations regarding protection of human subjects. If Part 2 programs or lawful holders is a HIPAA-covered entity, they may now disclose data for research purposes to any entity as long as they follow the regular HIPAA rules. And I'm seeing a trend in this where 42 CFR is trying to mirror the HIPAA rules so that we're not having so many different rules we have to follow and more strict rules. They're trying to mirror the two so that there's less restrictions for these patients and less hurdles that us as providers have to go through. You can go to the next. So as far as audits and evaluations, this is new. So an exception is if de-identified information cannot be shared, we can share now with auditors and evaluators patient identifying information. If that's a federal regulatory body, a state, local, whatever that is, we are allowed to share those if we cannot do it de-identified. We obviously want to try it de-identified first, and then they can re-disclose to their government contracts, subcontracts, and legal representatives. So court orders. This is interesting, but this is new as well. This is an exception to a written consent that court orders are allowed to authorize the placement of an undercover agent for up to 12 months into a Part 2 program. However, it's very clear in the regulations that they cannot be there to investigate a patient. If they're there to investigate a patient, it has to be known. But they can go undercover to investigate the facility or another, an employee, but they may not come in as an undercover agent to investigate a patient in any way. So this is just a quick screenshot of the things that you can share as part of the Part 2 records. So I'm not going to go into this, but this is the coolest just little screenshot that you can have up just to help remind you of when you can share the exceptions of having written consent. I'm not going to read this, I promise, but in November of 2022, there were some proposed changes to 42 CFR. So much like in 2020, they made those changes. There's a new proposal out for these more changes to happen. And the gist is again, like I said, they're trying to align them more with HIPAA so that there's not so many layers to these regulations. So if you go to the next slide, I just sum it up really quick, things to highlight if these possible changes happen. First, I want to say right now, those are just proposed changes. So right now, the changes have not been approved. So we need to still follow the current regulations that are in effect that I just went over. But the goal is to align them more with the HIPAA regulations so we have less restrictions. It just says this proposed rule would improve coordination of care for patients receiving treatment while strengthening critical privacy protections to help ensure individuals do not forego life-saving care due to concerns about record disclosure. So I think they are making moves in the right direction and not being so strict on these rules so that we can take care of our patients, but also still protect them from stigma and other things that they run into in the healthcare world. I believe that's my last slide. Do we just go one more? I think those are the links that I talked about more information. You can, those have everything you possibly need and more on those 3 links. So feel free to look at those on your own. And then does anybody have any questions about my piece before we move on to Dr. Fernandez's?
And you're welcome to unmute or put it in the chat.
All right. Well, thank you guys for letting me present that. And I now give you to Dr. Fernandez.
Thank you. And, you know, one of the things about 42 CFR Part 2, there's really good, again, is helping our patients, right? Making sure that they get the care that they need, they get the care on a timely basis, and then we're also protecting them, right? If you think of all the areas of care that we have out there, this is the one that has the most stigma out there. Because even some of us, when we first start, we have some parts of us that have unconscious assumptions and misinformation when it comes to the treatment of somebody who's using substances. And so very important to know that not only should we be trying to be very aware of it, but then also there are regulations that protect them. And so that's excellent. So thank you, Jamie. Thank you so much for not only sharing what has been the history, but also what are some of the changes that have happened. Okay, the other part that goes together with this presentation is what we call the ASAM criteria or level a model to match care. And why don't I start with a question, if you can type in the chat. What levels of care do you think exist or that you know of for people who are coming in for treatment for substance use disorders? What levels of care? When you hear that, what do you know exists? And you can guess, or you can, yeah, there you go. Inpatient, very good, Michelle. ASAM 3.7, oh, wow, somebody got pretty withdrawal manager, very good. IOP, exactly, inpatient, intensive outpatient, inpatient, outpatient intensive, very good. Detox, that would be another one, very good. Right, detox inpatient, partial hospitalization, yes. Lindsay, definitely. Some of you are getting very technical, and the rest of us, we're going to find out why the 0.5 or the 1. Why is it that we have those decimal numbers, and what does that mean? But that's right, Anthony. Inpatient, outpatient, we have outpatient, intensive, etc. Right? And we might have things like outpatient intensive care because we have somebody who is trying to hit recovery, but they still want to be able to keep up with some of the things they have to do during their week, right? And going inpatient fully, it's not something that is available to them, and they're at a point where they could. Now, how do we know that? How do we determine that? Well, there is a what we call the ASAM criteria, and we call it ASAM because it was developed by the American Society of Addiction Medicine, and it is a levels of care model. So in other words, it gives us a guide as to what type of care should we provide for our patient. How neat is that, right? How great is that to be able to know maybe just therapy does not work, maybe just medication does not work, and then there may be instances in which it does work. So how do we know the difference, and can we have one standard that all of us can use? What's really interesting about the ASAM levels of care model is the gold standard, is the best standard out there, but it's not used in every state. And so if you're watching us from another state, you might want to check and see if your state follows it. New Mexico does follow it because we recognize that we want to have something that is evidence-based, right? Because if we have something that's evidence-based, then we know we're providing the best match when it comes to care. So this ASAM criteria developed by the American Society of Medicine has different levels of care, and it tells us what are the appropriate levels. It was released, it's been around for a while. It was released 10 years ago, 2013. It's a matrix slide, and I'm going to show you that. So it has multiple dimensions. So all of this is a mouthful, but we'll go through them so that you can see the aspects. Now, for those of you who, this is providing substance-related treatments. For those of you who don't provide substance use-related treatments, you might actually be a puzzle piece to providing care for somebody who does have a substance use treatment. So maybe you are somebody who's working with vocational type of rehabilitation, right? And so your piece is super important in somebody's recovery from substances, even though that might not be your primary goal, right? So how neat that we get to be a team-based approach, right? We're going to talk about assessments, right? So remember we talked about it in the last a couple of presentations, how assessments and screening tools are important, and that's going to help us in terms of matching. We talk about distinct continuum of care. We also talk about episode of care. We'll explain that in a bit. And what's really nice about this model is that it matches DSM criteria, right? So it takes into account the severity, the diagnosis for substance use, but then also for other mental health issues, and it's user-friendly. As a matter of fact, you can go online and you can use tools online. Our state provides free training. So if you Google free ASAM criteria or ASAM training, you might come across, they're usually like about 4.5 hours. Some of the programs might give you a free book, so you actually get the ASAM book that you see in here. And what I love about the book is it has different sections that talks about different disorders, specific populations. It's a really well-developed guidebook. It has updated terminology, right, and new treatment perspectives, and like I mentioned, specific populations. I love, they have a really great adolescent section in which it talks again about how can you best match levels of care, and what are they? It gives you explanations about them, right? So notice that I talked about, let me start first with, we talked about screening and assessment. So this is more like a summary. Continuum of care, episodes of care. Very important that we understand what that means, what's the difference, and then we'll go into the domains and we'll see how we can match to the appropriate level of care, okay? So let's start with screening and assessments. Remember that last time we were talking about the difference between screening and assessment, and being that screening tools will tell us yes, maybe, or no, right now, right? What I mean by that is if we give, for example, the PCPTSD, the primary care PTSD screening tool, it's a 5-question. It's going to ask our patient if they experience a traumatic event, and it's going to ask them to see if they're experiencing some symptoms. And all it does as a screening tool, it tells you that if you get a score of 3 and higher, you should probably screen for PTSD. Now, it should never be used as a tool to actually diagnose PTSD. So it's important for us to know the difference between screening tools and assessment. Remember PHQ-9, we talked about that last week in terms of risk assessment. PHQ-9, probably not the best one. Remember, we talked about Colombia being the ideal one. But in terms of the PHQ-9, we can check how severe someone might be experiencing depression, right? So that's how it's a little bit different than a screener. Not only does it tell us yes and no, it's saying someone's really experiencing some pretty severe symptoms of not managing concentration, feeling bad about themselves. We should ask more questions. So PHQ-9, again, should not be used as an assessment tool, but definitely as a screener, as a diagnostic tool, sorry, it should be used as a screener or an assessment tool. So we want to know how severe symptoms are and find out why. Super essential in being able to match symptoms, because let's say you're experiencing depression or you have major depressive disorder as your diagnosis, and you're managing it well, right? And maybe your PHQ-9 is a little high, but you're still managing it well. It's not affecting your functionality. Maybe that's not an area that we need to address. So that's why it's very important to understand how the severity is affecting that individual. Another aspect that's very important, essential to understand in terms of matching to the right services is continuum of care. Understanding that I, Patty Fernandez, I'm not the sole person that will heal everybody, right? In every aspect of issues that somebody is presenting when they come to see me. But realizing that I have my peers, like we do here in this group, who are nurses, who are peer specialists, case managers, and we all work as a team. And understanding that sometimes we can provide those services to continue the care. We can provide them within one clinic, or sometimes we need to refer them out, refer patients out to another place. For those of you out in the community who are in private practice, being able to understand who else do you have, what are your connections in terms of referrals, right? Who might be good people, or at least people that you can consult in terms of where to refer. So for example, in our psychology board, there's a chat, right, where we can ask, is there anybody out there that provides any specific services about certain things in different levels, right? Can we send somebody else for legal issues? Can we send somebody else who's struggling with housing, etc.? And so really understanding that it's not just you, it's a team of us. Right. And what a beautiful thing, because think about it. I think most of us chose this field maybe from things that we experienced from our childhood or developmental time. And we really want to help. We want people not to suffer. And sometimes we make the mistake of keeping those patients and wanting to find out what else can we do ourselves without really like being mindful that there are other places where we can send them. And they can get much better care. So that's continuum of care. This one's a little bit similar, episode of care, right? This is an interesting one. Understanding that I'm not going to have the patient forever. So imagine for a minute that it's say, we are the best nurse school in the nation, and we are going to provide you with the best training. But just so you know, we're going to assign you to one teacher for the entire time. We really don't know how many years it's going to take you. So it might be 3, it might be 10, but you know, you're going to have that one teacher and she's going to try her best here. She's going to try their best. And you know, I'm sorry if you kind of don't get along with that teacher, there's no changing teachers. You're just going to have that one teacher. It would be very nerve-wracking, right? It would be horrible. It would be a horrible experience. So episode of care is not only teaching our patients what is care, but also being able for us to be mindful that it's limited, right? So if I'm going to provide CBT, it's going to be for this many sessions, and that it is okay that I am not the expert at everything, right? So maybe I'm here, I'm really good at providing treatment for trauma, but then maybe I need to refer them to somebody else, right? Who is really good, say, for example, with couples therapy. And they have really great experiences. If we're within a clinic, I can even say something like, you know, John, I know that you and your wife are experiencing some issues. What do you think about couples treatment? And then I'm sure John's going to say, well, but then what does that mean? Like, is this it for us? And let's again assume that we finish that episode of care, or whatever it was. I can offer to John to say, you can go to couples treatment. We do this here ASAP. You can go to couples treatments. You can always come back and we can address other issues if they are within what are my areas of expertise. And if not, I can send you to Kathy over there, who's really good with depression, for example. And so being able to eventually to teach our patients and empower them so that eventually they know how to use their own skills. They become their own therapists, and they can always check in with us, right? So it's not like that's it, done, and you never come back. We've had patients who sometimes, like in our clinic, we have stages. There are times that they may move from stages because they're struggling with something new, and maybe at that moment they're not managing it well. They don't have the skills for whatever it is, and they're wanting a little bit more therapy. We can definitely continue and start a new episode of care instead of this idea of that nursing school I told you, being there for years and years and never know really what the goal is. So very important. I heard somebody say today, like really explaining to our patients, what are the steps, what should they expect, what are we going to expect, and how long that is going to take. Super important. So understanding those two, continuum of care, episode of care. And if you look at this ASAM matching, what it does is, we talked about the screening. It definitely does take into consideration diagnoses. That's why I was mentioning the DSM. Remember the screeners and the assessment. So we look at how severe someone is in a specific area. And what I love about this model is it actually takes into account how ready the patient is, right? Because if somebody is not ready, we need to take into consideration that component. And we might use an episode of care where we're using motivational interviewing to see if we're able to collaborate with that patient in terms of treatment. Notice the dimensions, right? So there are 6 dimensions that get evaluated. So notice that we want to know how risky are they? How are they right now in terms of intoxication and withdrawal, in terms of biomedical issues, in terms of that would be like maybe they have the high blood pressure uncontrolled, maybe they have hepatitis, that has not been treated. Emotional, behavioral would be depression, PTSD, etc. Not diagnosed or maybe diagnosed but never treated. Recovery environment would be how likely is it my environment to be supportive of my recovery, right? So is it one where everybody else is still using, or maybe I'm out in the streets and I'm around a bunch of people who use, and then relapse potential, right? How likely am I to go back and relapse? Because we want to ensure that we keep our patients safe. Notice that I kept number 4 separate, and number 4 goes back to that readiness. So what we're going to see in terms of this 5, 1, 2, 3, 5, and 6, when we rate them, we go mild, moderate, and severe. And severe meaning that's when we have the most like really severe, we really need to pay attention issues, versus in that same scale from mild, moderate, and severe, it's mild, moderate, and very strong treatment acceptance. So that's a little tricky when you look at I'll show you the table because it feels like it's going the opposite way. But and I'll show you, but take into consideration what I wanted you to see here is we're looking at 6 areas. So what a great approach, right? So I am a therapist. This is my area of expertise. But when we're collecting data at other levels, right? So, so this relates to me as a therapist. This relates to me as a therapist, and I'm collaborating with my medical colleagues in terms of some of these other ones, right? And maybe I'm collaborating with case managers, social work, peer, to be able to know what's going to happen in terms of their environment. And then once we have all this data, then we get to decide those numbers that some of those people were putting in the chat, what type of level of care that you get. Is it outpatient? Is it intensive outpatient? So they're not inpatient, but they're working maybe four days a week for several hours. Is it number 3, medically monitor intensive inpatient, or medically managed intensive inpatient? And if you notice, as the numbers go up, the level of severity is greater. Therefore, they need a level of attention that is much closer than what it would be at the lower numbers, like outpatient, for example. Okay. Okay. So this is from the book. This is literally like pictures taken from the book. And so it actually goes into the explanation for every single dimension. It has questions. So I think this one has questions that are specific that you can ask. If you're in private practice, you might be able to collect like the behavioral part. If say you're doing therapy, and you might want to partner up with other organizations to be able to collect other information. In our clinic, when somebody comes to intake, they go to different stations, and each station is collecting information in these areas. So here's dimension 3, right? The emotional. And again, we're checking to see, is there either behavioral, emotional, cognitive conditions? Is there suicidality or other types of risks? Even cognitive issues, right? So if somebody comes to see us, and maybe they're coming with a lot of issues in terms of like learning, they're going to have a lot of difficulty when it comes to treatment. Therefore, we need to ensure when we match the service that we're actually matching them with a service that accounts for somebody who's struggling, right? So when you think of PTSD treatment, some of the handouts are pretty extensive. And so you have to make adaptations to the treatment. Otherwise, it does not work. And again, as I mentioned, dangerousness and lethality. Okay. And then the ability for self-care and social function. And like I said, the book can provide you with questions, and it also gives you recommendation in terms of what might be some questionnaires that you can use. So here are the other 6. So this is a table that I was telling you about, right? So you can use this table as reference, and you evaluate someone. So we evaluate John in terms of dimension 1, right? And so let's say that the nurses give him a measure, the Clinical Institute withdrawal assessment for alcohol, or alcohol scale. And we're trying to measure what's the potential for withdrawal, or how much intoxication there is. And they tell us, they mark it. And again, in some settings, this is formal. In our setting, it isn't this formal, but we are all gathering all the information. And then it's viewable to see at what level of severity are they at, right? So notice dimension 2, right? The Duke Health measures not only measure mental health, but it also measures other issues like physical health, and even perceived health. You gather enough data, enough that where you're getting to mark, where is this patient at? And this is just an example, right? Notice that here we have the readiness for change. So notice that I have it marked here. I put them by colors for the other sections. So is this person pretty ready to change, or is this person not very ready to change? Which one do you think? Remember that that's a trick one. If you can put it in the chat. Just curious. What do you think? In terms of readiness, what do you think? It's a little tricky, right? Don't get thrown off by the color. So remember, as the number increases in terms of readiness, that means that they are more ready. So I totally tricked you on that one. So for those of you who put no, it's okay. You can blame me. I tricked you. So the higher it is, the more ready the patient is. Okay, so just be careful if you're using this table when you have the book or go through the training. Be careful not to get tricked by this one. For all others, we definitely, the color does, and I added the color, the table does not have the color. I added more for visual help, right? So if we have a yellow for somebody for intoxication and withdrawal potential, we want to be monitoring this patient. But then, for example, here in terms of biomedical conditions is in the green. So that would mean that we're okay to kind of leave that to the side and address anything in the yellow, and anything in the red, it needs to be addressed immediately. Notice here are magic words for those of us who work with risk assessment: imminent danger, right? So if we assess someone at imminent at 3 or a 4, we need to address that immediately, whatever that is. And again, don't get tricked by this one. Okay, so let's check. Let me take off this excess so it doesn't confuse you. So let's check. Somebody with uncontrolled diabetes who has an A1C, for those of you who know A1Cs, 9.9, sugars are in the 300s. First of all, what dimension would you put it? And if you want to put dimension and severity, or dimension and number, where would you put them? Uncontrolled diabetes, A1C 9.1, sugars on the 300s. Okay, a 4. Somebody said a 2 or a 4. Okay, D. Okay, dimension 2. That's right. Okay, very good, Stephanie. Yeah, and Heather, very good. And we're putting, okay. So at a 2, definitely monitor. Right, and it's a little bit high, right? 300s. I mean, we have a nurse colleagues in here in this presentation. See, so probably a little bit higher, right? We really want to get those sugars. So it would be somewhere in here. Not sure. I leave it to my nurse colleagues. That's where we want to consult with them, and they would probably be gathering that information, not us. They will let us know at what level of severity. So it'll be like, hey, Patty, listen, we really got to send this patient to see the physician. They really need to get checked, right? So they will help us. That's why I love that team approach. Okay. What if diabetes was controlled? So we said dimension 2, you got it. So it's in dimension 2 because it's a biomedical condition. But let's say they tell us they have diabetes, but it's controlled. Where would you put it? 0, 1, 2, 3, or 4? Okay, Lias is a 1. What about others? Where will you put in? Yeah, so either a 0 or a 1. Yeah, don't forget that high, this would be if they have it uncontrolled. Very good. Very good. Yeah, so we would put it to the side. Okay, what about this one? Patient tells you, I am a 17-year-old gay male with parents that don't support me at all. What dimension and what number? What do you think? 17-year-old gay male with parents not very supportive about being gay. Dimension 6, very good. That's right. Recovery environment, very good. And so out of 3, okay, definitely not very safe. At D6, so there's no 6, but pretty high. Oh, dimension 6, never mind. Yes, dimension 6 for sure. Maybe at a 3, Heather. Okay, that's right. So we definitely need those parents on board, right? Otherwise, we're going to send that kiddo home and things are not going to go so well. It depends on the client. Experience or expectations? I'm not experience. Okay, depending on the, so if they're saying they're not supportive at all, and maybe their substance use relates to that, we definitely want to put it somewhere in here. Yeah, so we want more questions. I like that, Heather. Yeah, let's ask more questions. Okay, what about female patient with fentanyl use, daily pills, between 3 to 5 pills of fentanyl? What dimension would that be? Female patients, fentanyl use. Okay, 1. Where else would you, yeah, fentanyl use, yeah. Dimension 5, okay, very good. Relapse, that's right. We're talking about fentanyl. The rate of relapse is pretty high, right? Especially, let's say our patient tells us because they have unmanaged pain, whew, really, really high, right? So yeah, very good. Dimension 5, very good. What if that patient is pregnant? Fentanyl, yeah, 3 to 5 pills. What other dimension might you account for? That's right, dimension 2. We want eyes from the physician too. Very good. Okay, so great. So you got a little taste of what this table looks like. One thing to note, it's not cumulative. It's not like I got a 4 here and I got a 3 here and then a 2. So then you add the 4, the 3, and the 2. It isn't like that. You go by the severity. Whatever falls under this area, it needs attention. And then you prioritize it with your team. And then, and if you don't, like, let's say we don't provide services for certain things, I only provide therapy services, I'm referring that person out. I'm saying, hey, we got to make an appointment with your PCP, or we got to make an appointment, you know, I know this program called ASAP or whatever else other community place there is, and we're sending them there. Okay, so So I show you this, right? So this is just an example. And so then you match it to the services. So that's the last part of it. So then, you know, if we think of the person with some use, they probably would be in outpatient or even intensive outpatient. Early intervention, I'm glad that this is in here, right? Somebody put 0.5 in there. That's when the use is there, but it's not very strong, right? So with the patient with fentanyl, we want to know, is it an intensive outpatient or might it be a 3 or even a 4, right? So a very intense type of treatment. You'll see in the book, when you look at it, there's decimal points and it just matches. This is the same thing. It matches the type of service. The book, if you get it, it actually would even tell you what does it mean to be an outpatient service. If I call myself an outpatient service clinic, what does that mean in terms of an objective measure? Okay, so a great method to match services, considering many areas that we should, including how ready that patient is, right? Because what if you have a patient that says, my wife sent me and she said that if I don't come to, when I told her I don't want to go, she said, I'm going to leave you. So how ready is that patient? Remember those numbers, 1, 2, 3, 4, with lower numbers being not as ready. What would you think? What would you give that patient that comes in and tells you, my wife told me I need to come, otherwise she's going to leave me? I know some of you are going to say, ask more questions, but yeah, that's right. A very low number. That's right, Patricia. Very low number, right? So we need to work on motivational interviewing. So this ASAM matching of services model does consider or use, motivational interviewing as a way to get the patient there, right? Collaborative, not making them just like the wife, right? Because we're just gonna then nagging it doesn't work, right? So that would be another lecture later on craft or CRA approaches, where we're trying to talk about how do we work with someone collaborative. We even have one on motivational interviewing. So this is the last slide for it. I'm curious if there are any questions. If there are no questions, this has a list of references. If there are no questions, I'm going to put the slide for the nurses. You are welcome to go ahead, nurses, to use the QR code. If you're not a nurse, remember that you will receive a question, and the nurses, you also receive the questionnaire from Erin. And please fill it out. It will ask for your information for your attendance certificate. And Erin keeps track of if you attended and how long you attended. And Kyle just put in the chat the link for the nurses. So let's see, any questions?